But welcome to our September Hot Topics webinar. We're so excited to have you with us today, and we're going to have a fabulous conversation today about how to use APC data for some very special use cases, using data from multiple states to answer a single question. So I am pleased to introduce to you Professor Joseph Dieleman from the University of Washington. And I'm going to go ahead and turn the time over to him to start his presentation. And then at the end of his presentation, we'll have a Reactor panel. I will introduce them at the beginning of the Reactor panel, and we'll move forward from there. So go ahead, Professor Dieleman, and take it away.
Great. Thanks so much, Norm. I will bring up some slides. Okay, hopefully everyone can see my slides. I'll get started now. It's a pleasure to be able to present. Thanks, Norm, for setting things up. I'm really excited to be able to talk about this project. I presented to this group about, I think it was about 4 years ago, 3.5 years ago. It was at the beginning of this project that we called the Disease Expenditure Project. And now we're kind of at the end of the project, or at least the part that's funded right now. And I'm really excited to be able to kind of report back and highlight some of the work that we've done. So we call this the Disease Expenditure Project. It's led by myself at the Institute for Health Metrics and Evaluation, and we have a team of about 8 people, depending on how you count, that get to kind of work on tracking health expenditure by disease and by county in the United States. So that's what I'm going to present on today. So the impetus for this project is a report that was written by Baylor Health not so long ago that was talking really about strategies for state action to address healthcare cost growth, and identified this box on the right, these categories, as kind of basic pieces of information that were necessary to really rein in cost growth and to understand healthcare spending and financing within a state. And so, that report came out as we were just starting this project, but it really stands as a nice foundation because this is exactly what we're trying to do. The goal of our project is to look across all states and measure spending, by market, by geography, by service category, by health condition, and looking at the demographics of the patients as well. And so today I'll talk about that project, but this in many ways is kind of the foundation. So in the next 15 minutes or so, I'm going to kind of work through this outline. I'll start with a little bit about methods, because I think this is a group that might be interested in how we're making these estimates. Then I'll talk about some of our preliminary estimates. None of this is published yet. And so everything is preliminary that I'll share. I expect there'll be tweaks and adjustments as we go through the peer review process and as we share these estimates with different advisory boards. But these are the estimates we have at the moment. And then the very last slide just highlights how we might work together. Everything I'm going to present today will be, once we publish, will be publicly available. And we have an interactive website that we're putting together that should facilitate download. And so for anyone on this call and anyone in general that's interested in using the research for non-commercial interests, the data is freely accessible. And because part of our mandate really of this project is helping people use the estimates, we are keen to get the estimates out and really happy to help facilitate people using the estimates. So that last slide of working together in some ways is just talking about how you might be able to use these estimates. So starting with scope and methods, I'll move through this pretty quickly. I don't have a ton of time today, and it is a big project. But really, the goal of the project is to measure health expenditure and also utilization in kind of 9 billion different ways. And when I say 9 billion, what I really mean is we're taking the total health expenditure in the United States. We drop out a few pieces that we're not able to track, things like public health spending, or we don't have good data on the VA, for example. But we get at the end about 75% of total healthcare spending. And we want to split that out by county and understand the expenditure for each county and state. We're interested in breaking it into payer categories. So the categories we look at are Medicare, Medicaid, private insurance, and out-of-pocket spending. We look at type of care, spending, and the 7 that we look at is inpatient care, nursing facility care, ambulatory care, home health care, emergency department care, and retail pharmaceuticals. And all physician-administered drugs are part of our ambulatory care bucket. Thinking about demography, we split out the estimates by age and sex of the patients, as well as county, which I mentioned. And you can see in italics where we have ongoing work looking at race ethnicity that I'll present a little bit on today as well. And then really the main part of our work revolves around tying health expenditure and health utilization to health condition. So we look at a group of 148 mutually exclusive and collectively exhaustive health conditions. Those are categories like diabetes type 2, Alzheimer's disease, stroke, depression, child delivery and pregnancy. Those sort of categories are essentially the building blocks of what we're trying to estimate. And we find that measuring spending by health condition is valuable because we can line it up with disease prevalence and incidence estimates. Our project spans 2010 to 2019. We hope to update that through 2022, but right now the funding we have takes us through 2019. And maybe it's a reflection of how long we've been working on this, because when we started, the data through 2019 was all that was really available. So talking about the steps really quickly, I'll move through this quick, but figure again, this is a group that might be interested. We start by collecting as much data as we can on health expenditure in the US. These are our primary data sources. So you can see we use Medicare and Medicaid claims. We get those from ResDac. But then on the private or commercial market, we get data from the Healthcare Cost Institute, MarketScan, and Kythera, as well as P&R dental claims. Across all of those claims in general, we have about 60 billion claims. So it's a rather large project. Of course, we process each of these claims in bulk and try to build our estimates from it. But we also use data from ARC, from HCUP, and on hospital administration and case mix information. We use data from the MEP survey, as well as quite a few different data sources from CMS. The first thing we do in our process is take the claims and bucket them into encounters. So based on the same beneficiary, so person ID, location of service, and date of service, because our unit of analysis really is the encounter. So number of visits, number of prescriptions, number of admissions into a hospital or nursing facility care. Next is we assign a primary diagnosis for each encounter. So that is based on ICD diagnoses. We match to one of our 148 health conditions. This is a very long and cumbersome process because the 170,000 ICD codes don't neatly map, of course, to those 148. So there is a lot of estimation and analysis that goes into this. There are some one-for-one nice matches, but a lot of the 170,000 ICD codes take special treatment. So again, a lot of time put into connecting ICD codes to our 148 health conditions. Next is all of our data have imperfections. Sometimes that means they use zip codes instead of counties. Sometimes, like MEPS, they truncate the ICD codes to something more aggregated, and we really need the full disaggregated estimates. So we have a lot of kind of adjustments that, again, this is estimation. I should have maybe made that point. This is not an accounting exercise, but we're trying to adjust really statistically to address a lot of the imperfections in the different data sets that we use. And then we also have a small area model. Ultimately, for low prevalence diseases and low population counties, our samples of data are never going to fully capture, we just don't have a census, of course. And so we use a small area model to estimate and borrow strength across age, time, and when necessary, US county as well. We adjust all of our spending estimates for comorbidities. What we're really trying to estimate is the fraction of the spending that is attributable to each health condition. And so if you go to an outpatient visit for diabetes, but you also have ischemic heart disease, we will use regression analysis to figure out how to reallocate some of those resources to ischemic heart disease, because we know that's driving up the cost of the diabetes care that maybe was the primary diagnosis. And finally, our estimates are consistent with the national health accounts and the state health expenditure accounts. These are imperfect data sources themselves, but they are, kind of the official gold standard when you're looking across states. And so we make sure that all of our estimates are consistent with those sets of estimates. And this is the last slide on methods. It just kind of highlights for 2019, there was $3.8 trillion spent on health in the US. 3.2 of those 3.8 trillion was considered personal health spending. So, excluding capital investments and R&D and public health. That's really the target that we're aiming for. We wish we could capture all 3.2 trillion, but we don't have data on durable and non-durable medical equipment other than retail pharmaceuticals. And we don't have data from the VA, Department of Defense, TRICARE, IHS. And so there's just generally some gaps. And so at the end of the day, our project for 2019 captures $2.4 trillion. It's most of the major spending, it's Medicare, it's Medicaid, it's inpatient, it's ambulatory care, but there are those gaps and places for us to improve. So highlighting our estimates, I'm going to kind of just buzz through a wide variety of ways that you can look at this data set. But remember, it's kind of 9 billion estimates that can be aggregated or disaggregated in a wide variety of ways. So one way is to just look at payer or type of care spending estimates. These are the 7 types of care and the 4 payers that we look at. One kind of cool thing is you can look at changes over time because we have a 10-year time horizon that we're looking at. And so the first column here that shows growth rates is just the raw observed growth rate. The second adjusts for economy-wide inflation. And the next adjusts for the age and sex of the population, which we know is aging. And so you see that growth rates, get attenuated towards 0 ultimately when you take out the effects of inflation and age. Doesn't mean the spending isn't growing ultimately. It just means that we can understand some of this growth. And in many ways, as a researcher, I'm interested in this excess growth. After you take out the effect of age and inflation, where do we see there's major increases? And, in the way we break it down, there's a lot of increases in ambulatory care, home health care, and to some degree, emergency department care as well. And this period, just as a reminder, captures Medicaid expansion for many states. And so we see a lot of growth in Medicaid spending as well. So one of the hallmarks is being able to break up by disease. And again, these are just kind of examples of the way that we can cut the data. These are US spending estimates, but this same table could be made for each one of the 50 states and DC for that matter as well. These are our aggregated health conditions. So when we look across the US, we see that there is $254 billion spent on cardiovascular diseases in 2019. You can see that 63% of that spending was on over 65 population. You can see 45% of that spending was for Medicare, 15% was for Medicaid. And you can look at this for each one of the major health conditions. So these, again, are aggregated categories. If you want to look at the 148 health conditions, this is the more granular list. So this is obviously just a small subset of a table that's 148 columns long. The granular category that we look at the most, or that has the most spending when you break it up in our 148 categories, is diabetes with 146 billion, followed by this kind of obscure category that we call, for legacy issues, we call other musculoskeletal disorders. That's basically hip and knee and elbow pain. And that's at $109 billion. And you can see where the money is coming from for each of those health conditions, where it's being spent as far as the type of care, and which populations it is. This is just a classic age pyramid for the United States again. On the left, you see total spending by payer. And so there's more spending on the age group that's 65 to 69 than any other age group. And then on the right is just the per capita, same thing. But of course, as people get older, we spend more on them. in per capita terms. And the figure on the right is disaggregated by type of care. This is kind of, 4 years of work that kind of comes down to this one figure, which is county level estimates. So the previous iterations of this project made national estimates. And what we see here is our county level estimates. So this is age standardized spending per capita. And the yellow is where we see the least amount of spending, and the purple is where we see the most spending. And we see some kind of real patterns of Rockies and Southwest have less spending. To some degree, the Southeast have spending. But we also see a lot of variation within states. So, a state like Colorado, which we'll talk about in a minute, has, some pretty, extreme variation within states. So does Florida, for that matter, and Texas as well. We can make these graphs by payer. And so these are now age standardized per beneficiary figures. Medicare is on the left, Medicaid is on the right, and then private insurance and out-of-pocket spending. So again, you see these major patterns. These are all age and sex standardized. So the variation that we're capturing is really, not driven by the age of the population. This is one of my favorite slides. It's a little bit confusing at first, but I think it's one that could be really interesting to many people on this call. It's starting to answer the question of why does Utah spend less than everybody else on healthcare? And the colors here are in the legend on the bottom, but Utah spends less per capita on ambulatory care, inpatient care, pharmaceutical care, home health care, emergency department care, and nursing facility care. So those dots all to the left of the zero mean they spend less per capita in those places. But the color kind of tells us a little bit about why Utah spends less on care. And you can see that a lot of the reduced spending is purple or blue color, and that's because it's the youngest state in the country as well. And so we expect to see less spending in Utah. And of course, as Utah ages, this is kind of an important thing to be aware of and a factor to consider. Massachusetts is on the other end. Massachusetts is one of the states that spends the most on healthcare. We work closely with CHIA, and so this is something we've looked at a lot. But we see that some of the reason that Massachusetts spends more per capita on each one of the types of care is mostly because of these orange buckets, which is service utilization. And Washington in the middle is where I live, so I have an example of why Washington spends different. We spend more on ambulatory care, less on inpatient and pharmaceuticals than most other states. And again, that's driven by the kind of salmon orange color of utilization. Okay, I'm getting close to running out of time, and I want to get through a few more slides, so I'll just quickly move through these. These are growth rates, again, highlighting that we can look at by county growth rates. These are annualized and adjusted for age and economy-wide inflation, but again, we can look at these not adjusted for inflation, not adjusted for age if we want as well. This is looking at the increases in spending for each of the states that I called out before. So even though Utah spends less on healthcare than all the other states, they're spending more over time. And so this is looking just at Utah's increases in spending from 2010 to 2019 and asking the question, why does Utah spend more on health? So there's, it's a bigger population. It is a older population, so that than it was 10 years ago. So those contribute to more spending. You can see growth in Massachusetts and Washington, but the key thing is that the growth in spending for each of the states is distinct to the characteristics of the state. And again, being able to conceptualize that and visualize that, we think has value. I mentioned that we're doing work on race ethnicity. This is an old slide that only goes through 2016, but we have these estimates through 2019, and we have it by state to look at healthcare spending, per capita or per beneficiary in these key race ethnicity groups. We can decompose the differences just like we did in total spending. This is decomposing differences between Black non-Hispanic and white non-Hispanic by type of care. And you can see that some of the major differences are really driven by differences in utilization. So the blue arrows here are more or less resource utilization. And I think this is the last slide I'll probably stop on just with an eye on the clock. This is looking at healthcare spending that's attributable to modifiable risk factors. And so this is looking, again, across the US. When we look at a set of 79 risk factors, we see that high BMI or obesity is attributable. The most spending is attributable to high BMI. And the second is high blood pressure, followed by high fasting plasma glucose. So these estimates are currently for 2016, I believe, but we have updated estimates that we're making. And again, these are estimates that could be made at the state level. These are slides that are super exciting, and I will distribute to the group. But what I wanted to end with is this slide on ways that you might be interested in these data. First and foremost, they're going to be publicly available. It'll probably be at the end of the calendar year. We're going to be publishing in the standard sort of peer-reviewed outlets that an academic would normally work with. But we're really interested in working with non-academics who will more likely find the estimates of use potentially. And so if that's you, if you're interested in these data, you should feel free to reach out. Happy to kind of talk about where they're going to be available. And then, for more custom analyses, we're always excited to work with different states. We do work right now with Massachusetts, Wisconsin, and Washington. Different projects with each of those. And in two of those cases, it includes incorporating their APCDs into our data set, which we previously weren't using, and making estimates through 2022. Again, we're just really excited to try to make this project and the estimates being produced usable, at the national level, but especially at the state level. So with that, I will thank the lots of folks that work on the team. Some of them are on the call today, but all really dedicated analysts, and researchers. So project wouldn't have happened, of course, without lots and lots of effort and work from this group. So I will stop my slides and pass over the mic.
Thank you very much. We are now going to have our panelists turn on their cameras. Our Reactor panel today will include Kristin Paulson, who is the CEO of CIVHC, Colorado's APCD, Vishal Chaudry, who is the Chief Data Officer of the Washington Healthcare Authority, and Zhang, who is the Deputy Executive Director for Research at CHIA in Massachusetts. And so we would like to invite each of them just to take a couple of minutes and give us their thoughts as to what's going on, how they react to Professor Dieleman's presentation. So Vishal, would you like to go first? Would that be all right?
Certainly, yes. So thank you, Norm. Like you mentioned, I'm Vishal. I'm the Chief Data Officer for the Healthcare Authority in the state of Washington, which is the state's Medicaid agency, the Public and School Employee Benefits Agency, and the Behavioral Health Authority. I also oversee the state's all-payer claims database for the state of Washington. I've had the pleasure of working with Joe and his team over the past few months. They are supporting, in what's called an analytic support initiative, the state's healthcare cost board. So some of these slides were new to me, the others were not. I would just say the main thing that I get excited about is when folks talk about what's driving healthcare costs, right? They almost come at it from a unidimensional perspective. Like there's a driver of cost or a set of drivers. Whereas what we're realizing and what we've known for a while is that it's a multidimensional analysis. Yes, there's price and utilization and geographic setting, but then there are the core clinical conditions of the population, the demographic profile that is not static, right? It keeps evolving and changing because the population itself and the communities themselves are changing and evolving. And how do you take those factors into account and normalize for them while doing this analysis to create health policy recommendations that can have meaningful impact, right? So that's where the DEX analysis really excites me, because I think coupled with the cost and pricing and utilization analysis that can be supported by the APCDs, I think it can be a very, very powerful tool in our toolbox, if you will. So I'll stop there and hand it back off to Norm.
All right, thank you very much. Kristin, would you like to be next? Kristin Paulson from Civic.
Thanks, Norm. As Norm mentioned, my name is Kristin Paulson. I'm the CEO for the Center for Improving Value in Healthcare, and we administer the all-payer claims database for the state of Colorado. Joe and I actually met many years ago at the Academy Health Research meeting when he had one of his fantastic graphs in a poster, and I pestered him to no end about how he was getting his claims data and how he was integrating that with these other data sources to get some of these insights. And I think what we've seen over the years with IHME is really a realization of the potential of some of this data and being able to bring together these massive data sets that are publicly available, but really bringing them together and using the power of each of them to advance these insights is outside the reach of a lot of folks. And so I think, there's always ways that we can be improving things and improving our APCD data to better inform some of this work. But I just am really impressed with the work that your team does to show the power of what's actually already out there. Look at the data that's already out there, that's already in existence. And when we can bring it together, these insights are critically important because the differential in why prices are moving and why prices are increasing, that directly informs or needs to directly inform policy. And having evidence-based policies that are specific to the state that actually address healthcare cost drivers or decreased utilization or whatnot, we need those insights to be able to really start moving dial on costs and appropriate utilization. So I applaud you and your team for the work that you've done. I know this has been a huge lift, and I'm really excited to see what more comes out of it. So congratulations.
All right, thank you. And we're going to now, Z, are you ready?
Sure. Thank you, Norman, and for having me, and thank you, Joe, for impressive presentation. My name is Zhang, Deputy Executive Director at the Massachusetts Center for Health Information and Analysis. We are the agency on record for all the healthcare related data in the Commonwealth of Massachusetts, and looking at the healthcare cost and the drivers behind those. Big increases are a critical part of our mission, and as some of you may be aware, we have one of the highest per capita health care cost spending. So we have all the impetus to looking at what's driving, and as Vishal and Kristin mentioned, there's so many of those, and usually people just focus on whether it's utilization, price, or something else, but it's really all of them: demographics, geography, and how the market force really works in different regions of even within a state may have an impact. And we have been excited about the national work, and then talking with Joe about how we could apply the methodology to the state of Massachusetts to have a really better understanding of what's going on with our own data. Also infused in particularly our state's APCD. Just also to share with the rest of the audience that we also add our case mix databases and other databases, try to see what's really driving. And we're still at early stage, but have some promising trends that we look to refine and confirm and go from there.
Thank you. Let's go ahead and bring everybody on screen here. We have a little bit of a roundtable conversation, get all four of you together. So by the way, if there are members of the audience that have questions, I'm always mystified by Microsoft Teams. Some of you have chat, some of you don't. If you have chat, go ahead and put your comments in the chat. If you don't have chat, raise your hand and we will get to you. But we do have a question or comment here from Denise Lowe. We just make sure we call this out first. Impressive work. Thanks for sharing. This is a question for Joe. What improvements in claims data sources might be priorities for future work? Joe, what do you think we need to work on in terms of improvements in the claims data sources?
Yeah, thanks for the question. Thanks too for the kind words from the Reactor panel. It's nice to hear from a wide variety of people on how the data can and might be useful. As far as improvements to claims data, I tend to think that accessibility is the biggest issue. So we purchase all of our data, be it through ResDAC or from private providers of claims, and we spend almost as much on buying data as FTE for the team that does the work. It's an extraordinary cost. Sometimes it's licensing per year, other times it's buying per year, but either way, it's a huge cost. I think APCDs are a huge potential, but of course, accessing APCDs is a huge process, a huge fixed cost of going, by and large, from state to state to coordinate. And so I think, the claims data sets that we have, be them APCDs or Medicare, Medicaid, and a lot of the private companies now that are selling data are amazing. We use 60 billion claims and really mined a lot of great information out of them. I wish we had 120 billion. And the reason we didn't is mostly because of costs. And I think, democratizing some of that data to make it more useful to researchers, to state policy, research organizations and agencies is critically important. So that's my thought. Thanks, Denise, for the question.
All right, we have another question here. You said that your unit of measurement was the encounter, that you combine claims for the same person on the same day. You said an encounter was a visit, a prescription, and or something. Can you just talk a little bit more about the cluster of billions of claims into useful chunks? And I would also just maybe like to ask one or two of our panelists to talk about that as well. How, in your APCDs, how do you think about defining an encounter? So Joe, go first, and then whichever one or two of you want to respond would be great.
Yeah, so we found that for our research, there's a group that's interested in spending, and there's a group that's interested in utilization. And of course, there's overlap. Some people are interested in both. But utilization tells us a lot about access and disparities, and is really important. And so all of our estimates that I showed you on spending, we also have on the kind of utilization side. So it's either visits, and that's for home health care or ambulatory care, dental care, and so forth. And then there's admissions for hospital inpatient stays or nursing facility stays. And then there's prescriptions for retail pharmaceuticals. The way that we merge those is, by data set, we look at the person ID, the date of the service, and the type of care. So if one person has essentially two claims for an inpatient stay on the same date, we cluster those together. We've kind of learned from working with billing experts and physicians that you have to have a little bit of a buffer there, especially on inpatient stays, because they're not always coded precisely to the start date that they're supposed to. So we have a little bit of a window that we allow. But that's kind of the main process, is to look at person, type of care, and date of service. And we know that it's imperfect, but in the end, it allows us to boil all those claims together for a person, place, and time, and make it a single visit.
Does anybody? Well, which of the three of you would like to tackle that same question from your perspective of running an APCD? So I think Kristin really wants to answer this. Let's go.
I think probably my analytic team would be much better positioned to answer the question, but it really depends on the project and what we're trying to accomplish. I mean, we've got a number of calculated fields that we create within the APCD to help with some of this, so that we've got baked in algorithms to identify what we're calling an emergency room visit. What is the length of stay for a specific inpatient stay, so that we're kind of internally determining what that start end date is to lift some of that. But I mean, how you're going to be creating those usable clusters of data is going to depend on what you're trying to accomplish. And so, we do a number of different kinds of analytics. Some of them are looking at utilization, some are looking at costs, some of them are looking at disease states, some of them are looking at, episodes of care. And so it just kind of depends project by project, how you're going to be defining person, how you're going to be defining procedure. Attribution is another fun one. How do you determine who a primary care provider is? That also, it varies per project, but we've tried to bake in some things to make things a little bit easier for our team, but we use a variety of tools.
Thank you. We're going to go into this next question because now we've got a few here flowing. The very interesting question of how do you account for pharmacy rebates? And that fits into one of our major efforts of non-claims payment, adjusting for total cost of care. And let me give Z and Vishal first crack at that one. How do you think about pharmacy rebates in your data set? Are you able to do it? Is it something that you want to do? Have you given up? What are your thoughts? Z and then Vishal.
I have to just claim that I'm not really a sort of an expert on this, but I want to say what we want. Certainly, we want to have, the rebates incorporated into our sort of, calculation, but it's very hard, from getting the data and, incorporating to the data set. So it's really hard.
Vishal.
Vishal, I don't know if you have.
Yeah, because I sit in the agency that probably deals with the bulk of the Medicaid related rebates. We have the data, but it's not in the APCD. Again, there are so many different data sources available, and that's the part that I like about the DEX study is that, Joe, you guys are able to collate and collect those disparate data sources to be able to create a more comprehensive picture, right? And I commend the efforts that NATO and the APCD Council are taking in terms of ingesting non-claims based data into the all-payer claims databases. I may be in the minority here, but I still think that there's value in keeping clean, reliable claims data sources. Non-claims, adjustments, rebates, and there will be more mechanisms that pop up over the next 5-10 years that we'll have to adjust for, expecting that all of that can occur and co-occur within the same data schema, which is not generated from an analytic perspective, but from a data collection perspective, I think is naive. We've learned that over the years with creating massive databases and data warehouses that we tried to extend 15 different ways, and suddenly you couldn't scale it past them, right? So I'd say, yes, we need to find ways to integrate and use these other data sets in the analytic projects that we do. Do I think it'll be the best use of everyone's resources and time to put them all in the same spot? Maybe, may not be. I'm not fully sold on that. So I may be in the minority here in the group, but those are my thoughts.
Fantastic. And let's just go ahead and go on. Yes, go ahead.
Actually, this might be a really good opportunity for us to learn from each other. Different states, like how each of us are kind of, collecting, rebate data from PBM, from, big farms, and also, whether, each state has, really specific regulations, to give us authority to do such. And I wonder if I think we've been struggling a little bit, but I don't know if Kristin and Vishal, you have anything to add, on that regard.
Rebates are specifically tough. We have been collecting drug rebates for several years. Our authority initiated actually with a bill that required us to start looking and reporting on those rebates. And so we continue to collect those and report on them. 2 years ago, we added another field in there. So we collect aggregated rebates because you can't get down to the contract or specific drug level. Our payers, had a very hard line on that one. So we collect aggregated generic brand and specialty by payer. But now we also collect by therapeutic class. So that was a new refinement that we started collecting 2 years ago, was rebates by therapeutic class, so that we can start identifying which drug types are actually driving some of those largest rebate dollars. We've just got a full year of that data now to start diving into and really looking at. So we don't have any insights on that yet, but that's sort of the next cut we took to try to get closer to how would you even, how do you compensate for this, or how would you be able to pull some of this information in within an analytic, exploration to account for some of those rebates. And then there's, the challenges that the rebates are not counted in the patient out of pocket. So, attributing that rebate in the appropriate spots at the appropriate place. I think for rebates themselves, I actually agree with you, Vishal. I don't think that baking rebates into the claims is going to be something that is realistic or really helpful, but being able to figure out how we bring those considerations in through analytics, I think would be very useful. So hopefully we'll have some sort of new insight into rebate distribution, but we're as flummoxed as I think everybody else is.
Very good.
Yeah, and just building on that, the state of Washington from a legislative perspective, from a statutory perspective, the all-payer claims database, exists and collects claims-based information for a good 70% of the population in the state. The overall affordability and transparency statutory regime also includes our drug price transparency initiative and the prescription drug affordability board initiative. Together, the opioid claims database, drug price transparency data, prescription drug affordability data, which have different mandates, right? They feed into and support the healthcare cost transparency board. And that's where the purpose and the use of these data, some data are good enough to be used in an aggregate way to inform health policy. Other data, you need the gnat's ass detail, if you will, to be able to assess true utilization or access points or pricing issues, right? So it depends on what type of data you're looking at, under what circumstances, for what purpose. And I would encourage us to maybe take that into account as we improve our overall data paradigm.
Joe, did you have anything to add on pharmacy rebates or non-claims data generally?
So I would second everything that was said and how challenging it is. Right now we're not incorporating rebates at all, and our study really is claims oriented. So most non-claims spending we're not capturing. We do go to considerable effort to get estimates for the uninsured. So that's the part of our study that's not claims based, but pretty much everything else is.
Okay, let's go ahead and move on to Jim St. Clair's question. Any thoughts about next steps in APCD modeling, such as analytics, digital twin, etc., and then forecast changes in demographics, hospital closures, etc.? Wow, that seems kind of an ambitious question. So, Joe, why don't you take the first crack at that, and I'll let the other three have a moment to think if they have anything to add.
Great. So, lots there. I'll comment on a few of the pieces. So we are in the process of adding in 2 APCDs from Massachusetts and from Washington. We have projects with agencies within each of those states, and we're tremendously excited to do so. For one reason, it allows us to go beyond 2019 to much more recent estimates. And for the second reason, I think it will make the estimates of more utility to users in those states. And the reason is, we're a small research group in Seattle. Our estimates can seem somewhat, of course, foreign to anybody, but if they've incorporated the state's APCD, they seem like they may have a little bit more legitimacy. And if they, of course, do improve our estimates, and they reduce uncertainty in our estimates, those things are true from a statistical lens. But I think the perspective or perception of the project changes as well as soon as we're able to incorporate APCDs. So, and I'll pass it to the panel for the other pieces.
Yeah. Who dares to go first on this? And there's just a lot here.
I can speak to
Vishal?
a little bit maybe about the I like that thought process of creating analytic or digital twins. There are so many of the use cases that can be promoted and supported, if you will, without sharing actual client data. So I think APCDs in general, starting to create analytic resources for the purpose of, democratizing the data and making it available for broader analysis without compromising the privacy and security of individuals' data. I think that is something that we ought to be looking at as not just an analytic use case, but as a core competency that can be built into the APCD infrastructures. So I'm excited by that thought. Your second part about forecasting changes in demographics and hospital closures, et cetera. Again, claims present, I guess, one set of variables in a multifactorial system that you get, confounding variables from as far away as, federal law changes. So I don't know how much of that modeling will be useful. As a data geek, I think it'll be really fun to do. I just don't know to what degree it'll be useful. I'll pass it on to Zhang or Kristin.
I can quick comment on the forecasting piece. We've done some of that. And I showed some slides that kind of highlighted this. We kind of break the spending increases into kind of 5 major things. There's changes in population size, population age, disease prevalence, utilization, and prices and intensity of care. And so we have done some work modeling each one of those 5 things. In some cases, those 5 things are already modeled, right? There's forecasts of population demographics and size, so that's done for us. There's a number of projects that forecast disease prevalence, and then we really focus on more of the health services pieces. I think they're tremendously exciting. And I always highlight, we have a couple of forecasting projects. I highlight to people that, this is one plausible scenario based on past trends and relationships. That's what our forecasts are. We don't have a crystal ball, of course. And it says that, if things continue the way they have in the past, and we can incorporate uncertainty appropriately, this is the direction you're going. And in some ways, it's going to be a counterfactual to reality. The policymaker, of course, will determine the reality. It won't be what we forecast, of course, because there will be changes. But as a counterfactual, a base place to start, it can be really useful, has been our experience. So, over to the panel.
Kristin.
I was actually going to build off, comments from both Vishal and Joe regarding democratizing the data and really figuring out new ways to get the data into the hands of people who can work with it. That's something we've been talking about and thinking through and working on at Civic for a number of years, working to get researchers and other folks to really recognize the value of de-identified data. the granularity of claims data, even if you're stripping out all of those identifiers, is still just incredible. And so, but it does take that extra step to really get folks to think past, oh, but I can't have days of service, or oh, but I can't have this, to see what they still can do with the data. Another piece that we have done over the past couple of years is every single one of our, or virtually every one of our public reports has a downloadable data set behind it that can be accessed for free by anybody who wants to use it. So including our community dashboard, which is probably one of our largest interactive reports, all of the data powering that is downloadable and available for free to anyone who wants it. And so, we really are always looking for opportunities to get the data in that really usable format into the hands of people who can, move it forward. We're talking with schools of public health about, can we put our data in place so that you guys can be training folks on this data? So it's a de-identified data set, but you've got, entire classes of MPH and PhD students who are learning about this data and learning what it can do. And so, I don't really have anything more to add on the forecasting piece. We also would love to be able to figure out how we can make the data do this accurately and forecast, especially when we're looking at major impacts to health systems, hospitals going under, et cetera. But we're not quite there yet. But just wanted to follow up on that whole data democratization component that Vishal brought up.
Very good. We've got 5 minutes left. Joe, I'm assuming you're okay with us distributing the slide deck upon request. Should we have them contact you?
If people could contact me, that would be great. We're under embargo with the journals we've submitted to for all the reasons that, but with collaborators, and I use that broadly, we're very comfortable with kind of sharing things pre-publication. And so please reach out. Maybe I'll put my email in the chat for those of you who have access to the chat. It was also in the slides. So.
That would be great.
And it sounds like the recording will be available as well. So.
Yeah. So let's do this. We've got 4 minutes left. So each of you take 30 seconds or less to just give your final thoughts. We'll go Z, Kristin, Vishal, and then Joe.
Well, I just want to say thank you, Joe, for the good work, and also really, thank you, Norm, for organizing this, and also it's really a great opportunity for all of the states to learn from each other, which is really very valuable.
Thank you, Kristin.
I just think this is a great example of what we can be working towards, and what the improved data quality and improved data completeness from the APCD side can help inform. The work that IHME has been doing is going to be really critical to counties, to states, to the nation, and I think we have a part to play in helping make that usable.
Vishal.
Ditto to everything that's been said. The only one thing that I might add is we as analysts and researchers and policymakers sometimes get hung up on the actual numbers. Oh, my number doesn't match your number, but it doesn't matter. It doesn't matter, because directionally we're building a complementary, if you will, set of knowledge base that can be used to promote folks in the direction that we're all wanting to go in, which is better healthcare, more valuable healthcare for everyone, right? So I would just keep that in mind. Say, all analysis is good analysis because we learn from it.
Good, thank you. And Joe, to wrap us up.
Yeah, I'll just thank everybody for joining today. Thanks for the panelists as well. This is a project that has dominated my life for the last few years, so I'm quite passionate about it. But if you are interested in it, please reach out. Happy to talk your ear off more on things we think we've done well and places we hope to improve, and ultimately how we hope the data can be useful to potential users. Thanks very much for the opportunity to be here.
Great, thank you very much. And as I just posted in the chat, we would invite you all to join us again in September for our September Hot Topics webinar. As we will be talking about hospital data in September, and we may have an exciting announcement. So I will leave the teaser at that. And thank you all. Thanks for our panel. Thanks, Joe, for being here. And thank you, everyone, for joining us for today's Hot Topic series. Goodbye.
Thanks so much.
Thank you.